Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of the MRCP within the last 5 years and want to help you do the same. We're not associated with any MRCP examination organizations, and the materials covered are by no means an exhaustive list of what can come up in your exam, and indeed are not intended to be used as medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is on squamous cell carcinoma, or SCC, under the section of dermatology. So what is a SCC? It's a malignant neoplasm of keratinocytes, and it's the second most common skin cancer after basal cell carcinoma. If you want a recap of our video on BCC or basal cell carcinoma, please click here. As for its epidemiology, it's most common in patients above the age of 40, and there is a direct correlation with countries with high UV light intensity and Caucasian skin, such as Australia and New Zealand. It has a male to female ratio of 2:1. As for its risk factor, as we discussed, UV radiation is the commonest risk factor to develop SCC. The other risk factors include smoking, immunosuppression, cutaneous injuries, chronic inflammation, arsenic, genetic syndromes such as xeroderma pigmentosum, HPV virus, and polycyclic aromatic hydrocarbons such as tar. SCC can present in quite a variety of signs and symptoms, but frequently it has a scaly hyperkeratotic skin-colored erythematous firm papule or nodule, and this papule or nodule could potentially ulcerate and or bleed. Sometimes it could also present as keratocanthoma, in which case it's normally quite rapidly progressive, and it presents as a dome-shaped nodules with a central keratin-filled plug. So this picture is shown to give you a classic and quite an extensive picture of a squamous cell carcinoma. As you can see that this is presenting and affecting this patient's left-sided cheek. In terms of the investigations for when you're suspecting an SCC, it's really important to take a thorough history, thinking about all of the risk factors that we talked about. And then this should be followed by clinical examination, which will be a complete cutaneous examination as well as examination of the lymph nodes. And then if you're finding a lesion that is suspicious for a potential SCC, you need to be taking the biopsy of that lesion to confirm the diagnosis. In terms of treatment of it, similar to BCC, Mohs microscopic surgery, which is a surgical excision technique with histological intraoperative control of tumor margin, is the gold standard of treatment. Radiotherapy can sometimes be used, especially if the disease is advanced and has further metastases. The prognosis of SCC, if there is appropriate treatment, is relatively good. It has a 92% cure rate over 5 years with appropriate management, and 5-year survival rate in metastatic disease is about 25%. The disease association that's particularly important for you to know is any type of long-term immunosuppression. The classic case that could come in your PACES examination are patients in various stations, such as the abdominal station, that could be presenting with, for instance, a liver transplant or a kidney transplant. And you would, if you look closely on their skin, you could see multiple surgical scar and resection of previous skin cancers, such as SCCs or BCCs. Immune deficiency syndrome, such as HIV, a chronic inflammation, such as chronic leg ulceration or chronic osteomyelitis, and finally, some rarer genetic conditions, such as xeroderma pigmentosum, or potential associated disorders. So let's do some questions. A 50-year-old Caucasian man presents to his GP with a rapidly growing dome-shaped nodule over the last 2 months on his left earlobe. On examination, there is a central keratin-filled plug on top of the erythematous surrounding skin. What is the most likely diagnosis? A, BCC, or basal cell carcinoma, B, malignant melanoma, C, keratocanthoma, D, cellulitis, E, eczema. So reading this vignette, there are a few things that should hopefully lead you towards the correct diagnosis. A, the fact that this is a middle-aged Caucasian man. B, the fact that he's presenting with a rapidly growing dome-shaped nodule for a period of 2 months, which is relatively a short period to have the symptom. And finally, the area that this is being affected, which is the earlobe. And the last point to consider is the way that the lesion is described in the question vignette. So it has a central keratin-filled plug on an erythematous base. So reading all of this, if we go through all of the options, BCC is not going to be the correct option because this is not classically describing your pearlescent nodule. Malignant melanoma is not going to be the likely option because this is describing a very rapidly progressing case and specifically is saying that it's filled in with a central keratin-filled plug on an erythematous base. As a result of that, cellulitis is not going to be the correct option. He is not complaining of any temperature or infective symptoms. And eczema is completely irrelevant in here because this is not the definition of an eczema. Eczema doesn't cause dome-shaped keratin-filled plug. So really, by definition, even if you don't know the exact correct option by rule of exclusion, you should be getting to option C, which is keratocanthoma. That is the correct option in here. Thanks for listening to this episode of Bite Size MRCP. If you like what you heard today, give us a thumbs up and hit the like and subscribe button to make sure that you don't miss out on our next episode. Let us know in the comments which topics you would like to hear in the future. See you in the next episode.